I am going to talk a little bit today about bipolar disorder. So, what is bipolar disorder? Bipolar disorder, also called manic depression, is a mental disorder that affects the sufferer's mood. Those suffering from bipolar disorder suffer from severe mood changes and manic episodes in which their moods are extremely high, or depressive episodes in which they are extremely low. The symptoms of bipolar disorder, which we'll talk about in the next slide, are often severe enough that they interfere with the sufferer's ability to function and carry out daily activities. There is no cure for bipolar disorder, and it is a lifelong condition, but it can be managed. Although it isn't known exactly what causes bipolar disorder, doctors and scientists suspect it may be related to certain factors. Those who suffer from bipolar disorder have physical changes to their brains, making them unlike those who do not suffer from bipolar disorder. The significance of those changes, however, are not yet known. Those suffering from bipolar disorder may also have an imbalance in brain chemicals called neurotransmitters in the circuits that receive them. One neurotransmitter being looked at in relation to bipolar disorder is serotonin, which relates to sleep and wake cycles, mood, impulsivity, learning, and memory. Researchers also suspect bipolar disorder may be related to genetics, as someone with a close relative who suffers from bipolar disorder is more likely to suffer from bipolar disorder themselves. It has also been considered possible that stressful life events or drug use can trigger an onset of bipolar disorder. However, there is no solid link to any of these factors, and the causes of bipolar disorder are still just speculation. Bipolar disorder can look quite differently depending on whether a person is experiencing a high or a low. Symptoms can last anywhere from hours to years, though children tend to cycle through symptoms more rapidly than adults do. Sufferers experiencing manic episodes experience extremely high moods and excess of energy that causes them to be more active than usual and take on more tasks than usual, trouble sleeping at night, whether that's enough or at all, a likeliness to be agitated, irritated, or distracted, racing thoughts and a need to talk, or be excessively silly. They also experience very grandiose ideas and very inflated ego, and can be impulsive to the point of engaging in very risky behaviors, such as impulsive gambling, substance and alcohol abuse, or engaging in risky sexual behaviors. Someone experiencing a depressive episode is experiencing the total opposite of what someone experiencing a manic episode does. Sufferers experiencing a depressive episode have extremely low moods, little energy or will to do things, trouble sleeping, but maybe too much as well as too little, trouble concentrating, trouble remembering things, and may eat too much or too little. Sufferers experiencing depressive episodes also experience feelings of worthlessness or guilt and take little to no pleasure in daily activities, even ones they've previously enjoyed, to the point that they become obsessed with death and suicide and may potentially self-harm. Having a manic or depressive episode severely limits the sufferer's ability to function at school or work or in their relationships. A third type of episode, hypomanic episodes, share the same symptoms as a manic episode, but not to the extent that they severely limit functionality. What's more, some may also experience manic and depressive symptoms at the same time. Anyone having either a severe manic or severe depressive episode may also experience psychosis, in which they lose touch with reality and experience hallucinations or delusions. For example, someone experiencing a manic episode may be deluded into thinking they have special powers or an inability to be hurt, while someone experiencing a depressive episode may be deluded into thinking that they've done something wrong and everyone knows and hates them for it. Severe episodes of any kind may require hospitalization. If it is suspected that someone has bipolar disorder, seeing a doctor is the first step. A mental health care provider may discuss thoughts, feelings, and behaviors with the patient or close friends or family, or ask the patients or their families record their thoughts, feelings, and behaviors for comparison to bipolar disorder symptoms. Their mental and physical health records are checked extensively. Generally, bipolar disorder is typically diagnosed in teens or young people in early 20s, though it may be diagnosed earlier or later. Doctors face a special difficulty in diagnosing children and teens with bipolar disorder because their age makes them naturally prone to mood swings. What's more, children diagnosed with bipolar disorder often cycle through their moods much more rapidly than adults do. It takes more careful examination of the behaviors present and what's developmentally appropriate at each age. Children with bipolar disorder are sometimes misdiagnosed with attention deficit hyperactivity disorder or behavioral problems, though it is possible for anyone with bipolar disorder to have other disorders as well. The nature of a child's bipolar disorder may also change, and it's important that their treatment also changes should this happen. So now I'm going to play a short clip. It relates the story of a girl that was diagnosed with bipolar disorder pretty young at about age 5. And you'll hear a little bit more about the feelings her mother has dealing with her daughter's illness, and also gain some insight into her child's illness that details a little bit about what it's like to have bipolar disorder.
I started to notice in preschool that her behavior was different than the other kids her age. Sometimes she'd be really happy one minute, and all of a sudden I'd look in the rearview mirror and see her face look really upset, and she'd start freaking out about something that had happened a long time ago and worried that was going to make her die. Her preschool wanted me to have her evaluated, and at that time I had never even heard of a 3-year-old undergoing a psychological evaluation. I felt really bad about myself as a mom. I thought, I am just not doing things right. I was resistant to label her with anything, and I gradually came to realize by kindergarten, well, she is being labeled anyway. She's being labeled as the bad kid, the naughty kid, the girl that doesn't listen.
Kids with bipolar disorder have some awareness that something's wrong, something's not right. They're doing things that are different from their peers. They're having a harder time functioning, getting angry, getting irritable, feeling inexplicably really sad.
A really low point was when I was reading her a book at night. She just all of a sudden started sobbing and said, I just feel like I don't belong on this planet anymore. By then, I really knew that something was seriously going on. You'll do anything when you're that desperate to help your child stop suffering.
For many families, it's a tremendous relief to receive the diagnosis of bipolar disorder. It's an acknowledgement that no, parents aren't crazy. No, it isn't a bad child. That they have a bipolar disorder, and it can be named and it can be treated.
When the psychiatrist gave her a test to rank her own depression, it was like off the charts. And she had, I remember what I handed it to her. On the one hand, it was kind of a good feeling because she identified the questions that were being asked, and it was a way for her to articulate it. Where she hadn't really been able to before. It was just like that, like stupid. And now she saw all these questions that she is like, yes, this is how I feel all the time.
I don't think it's clear with any child where they're going to end up as an adult. Sadie is likely to have ups and downs throughout her life. How extreme? It's hard to say.
The medication definitely helped her. She's a pretty normal little 11-year-old girl. I think about what it would be like if she wasn't medicated, and I still sometimes have hopes that we can take her off it. But without it, I just felt like she was losing her childhood.
Okay, so personal needs. A child or teen with bipolar disorder has special personal needs. The first is medication and therapy. Effective management of bipolar disorder must include some form of treatment to prevent symptoms from getting worse. Effective treatment differs from person to person, but mood stabilizers such as lithium, Depakote, Topamax, or Lamictal for teens over 16 may be diagnosed. If a child experiences psychotic or aggressive episodes, antipsychotic medications such as Risperdal, Seroquel, or Abilify may be diagnosed. Children and teens with bipolar disorder may also undergo behavioral or family therapy in combination with or in place of medication. The importance of therapy is not to be understated. According to a publication by the American Psychiatric Association, intensive behavioral therapy can help patients get well faster and stay well longer, and family therapy helps educate the family to ensure children and teens are sticking to their treatment plans and helps patients develop interpersonal coping strategies that help them to control their symptoms and function in society. Children and teens with bipolar disorder also need an incredible amount of support as they navigate their daily lives, school, and struggles of growing up at the same time that they are navigating their illness. Imagine not being able to control or understand your thoughts and feelings. Imagine constantly cycling through your feelings from the highest highs to the lowest lows. Imagine seeing things that aren't there. Imagine being so overwhelmed by your own feelings that you need a hospital. This can be scary and confusing, and they need support to stay safe. There's an added level of support that is needed because children and teens with extreme episodes are at risk of self-harm or needing hospitalization. In order to be effective supporters, families need a fundamental understanding of what bipolar disorder is, how it is managed most effectively, what their child's treatment includes, and what may interact with their child's medication, as well as tracking their symptoms and making sure their child is taking any medications prescribed. Doctors can guide families on these topics. Developing and sticking to strict routines around daily activities, such as sleeping, exercise, and eating, may help alleviate bipolar disorder symptoms. Getting enough sleep is incredibly important. It is also important that children and teens with bipolar disorder have low-stress home environments, as stress can trigger episodes. Relaxation techniques, self-expression activities, and effective communication at home can lower stress. Mental illness, such as bipolar disorder, can strain relationships, especially in the home. Parents may experience guilt, stress, fear, and frustration relating to the child's illness. Siblings, especially younger siblings, may not understand what is going on. Everyone shoulders the responsibility of being a supporter and being informed. The child or teen with bipolar disorder may act out or say hurtful things during an episode, further damaging relationships. Many sufferers are socially impaired and may be unable to relate to the feelings of others. Studies have found that the stress of a family member's bipolar disorder is great enough that families coping with the disorder are less organized, less cohesive, and experience more conflict than families with healthy children. This is worrying because, as stated in the previous slide, a lot of pressure is placed on families to manage a child or teen's symptoms with them. They're responsible for monitoring and tracking symptoms, managing episodes, and assisting in recovery. They're also responsible for knowing how and when to access outside help. Being a caregiver can mean the caregiver giving up their own wants and needs, taking time off of work or school, and potentially shrinking their social circles to deal with their family members' needs. There may also be added financial costs. The caregiving roles families must take on can be mentally and physically exasperating, but are of paramount importance for a child or teen suffering from bipolar disorder. So what does bipolar disorder mean for the classroom? Bipolar disorder does not affect the sufferer's intelligence level, but can affect their ability to learn and benefit from instruction. The disorder affects cognitive abilities, like the ability to concentrate, remember, or think clearly. Students with bipolar disorder also tend to be disorganized and unmotivated and have difficulty sitting still or quietly and completing tasks. They also have difficulties in handling change or stress and are prone to angry outbursts. Furthermore, their condition may cause them to be excessively late or absent. Having bipolar disorder does not necessarily mean that a student has below average intelligence, but it does mean they have special concerns that affect their ability to fully benefit from classroom instruction. Students with bipolar disorder whose symptoms affect their ability may qualify may qualify for special services under the Individuals with Disabilities Education Act and Section 504 of the Rehabilitation Act of 1973, prohibiting discrimination against individuals with disabilities and ensuring equal access to education. Students with bipolar disorder may qualify for services under IDEA and the other health impairment and emotional disturbance categories, or under Section 504 if not meeting IDEA's stringent requirements. Specific services and modifications for each student will be recommended after evaluation. Depending on the findings of the evaluation, placement in a regular classroom or alternative placement may be recommended. Because bipolar students may be affected by stress and change, placement in a low-stress environment is important. Overcrowded, overstimulated, noisy classrooms can have a negative effect on the student's ability to learn. Some students may even need placement in resource or special education rooms for most or all of the day, in self-contained classrooms, or even transfer to a therapeutic school. Some districts without the resources or trained staff to teach bipolar students may even cover the cost of tuition for therapeutic schools to ensure access to a free and appropriate public education. Just as the family needs to be supportive, the teacher needs to be supportive as well. Bipolar students are prone to outbursts, mood swings, and inappropriate comments and behaviors. An effective teacher would need to be educated about the illness and be patient, encouraging, and compassionate to their students' struggles. Discipline may be challenging because disruptive behaviors stem from the student's disorder, and the teacher must take this into concern and refrain from being overly harsh and critical, even if that means overlooking minor infractions. Teachers must also monitor and manage severe mood swings. Bipolar students' behavior may also affect their peers. Bipolar students, as mentioned, may be socially impaired. Poor social skills and ability to relate to the emotions of others can affect the student's ability to develop meaningful relationships with their peers, while irritable, moody, aggressive outbursts can affect their ability to maintain any relationships they do make. They're very likely to be bullied or be a bully. However, proper treatment and therapy may make a bipolar student more successful at forging and managing relationships. Disruptive behaviors in the classroom, however, is still likely to disturb other students' learning. There are some accommodations a student with bipolar disorder would benefit from. Those specific modifications and accommodations will be recommended in the student's 504 and individualized education plans should they have one. Because bipolar students are easily distractible, seating near the front of the room or noise-canceling headphones during independent work may help them to stay focused. They may also benefit from additional time to complete assignments, tests and quizzes, and modified versions of them, or the ability to verbalize their answers. As they are easily overwhelmed and frustrated and have difficulty completing tasks, they may benefit from lessons and assignments being broken down into smaller parts. As they are often disorganized, they may also benefit from organizers and checklists. Bipolar students may also benefit from breaks to a designated, quiet, safe place when they begin to feel overwhelmed to prevent them from acting out. Finally, they may benefit from placement in social skills groups led by guidance counselors or behavioral specialists. Transition services are services that plan for a disabled student's transition from the elementary and high school world into the adult world as part of their IEP. IDEA requires that transitional service planning begin no later than 16, though it typically begins at 14 years of age in the state of New Jersey. The plan is developed based on a student's strengths, interests, and preferences to develop post-secondary goals and means to meet those goals relating to their future education plans, whether college, vocational training, or continuing adult education, employment, and independent living plans, including daily living skills and related services. Bipolar students would benefit from transitional services relating to daily living skill instructions that would help them learn and practice social skills to deal with social impairments, money managing and budgeting skills to prevent impulsive spending, coping skills to tackle adult stressors, decision-making skills, and medication management. Related services such as enrolling in substance abuse programs may benefit bipolar students who struggle with substance abuse, a common risky behavior for bipolar sufferers. They may also benefit from employment and education goals and services, such as attending college fairs, learning more about how to manage courses and register the disabilities with a potential school, or attending job fairs and learning resume and interview skills. This is of paramount importance because bipolar sufferers tend to have lower rates of employment. The Americans with Disabilities Act of 1990 prevents discrimination of individuals with disabilities in a number of areas, including employment. The Act requires that disabled workers have equal opportunities to employment, protection from being fired because of disability, and the right to receive reasonable accommodations. Bipolar disorder qualifies as a disability since 2008, thus those with bipolar disorder have the right to receive reasonable accommodations for success in the workplace. Workplace accommodations, however, do not cancel out their employees' need to perform their essential job functions, and must be reasonable and not causing undue hardship on the employer. Because bipolar disorder is a mental disorder, an employer may require corroborating documentation from a medical health professional, stating that the disorder exists and requires accommodation, though the employer is entitled to no more information than to establish the existence of a disorder and the need for accommodation. Some possible accommodations that can be made for bipolar workers include flexible scheduling to combat absenteeism, job restructuring, reassignment to a more suitable vacant position with a comparable salary, the allowances of frequent breaks from work, access to water and bathrooms to combat side effects of medication, or workstation barriers to minimize distractions and produce comfort for depressive social withdrawal symptoms. So that's it. These are some references that I used when creating this Prezi. And thank you for sitting through the presentation with me. I hope it wasn't too painful. And thanks so much.